innovative, I think, presentation for you this morning. So again, thanks for spending your time with us. I believe we might have some new people on the line, so you might be interested to know a little bit about advanced practice in British Columbia. And this particular session is called Sharing Education to Support the Growth of Recovery-Oriented Systems. So really it is a bit of a different presentation and a bit of a different way in which we're going to work through this material today. So we look forward to your feedback, and we will send you a link at the end of the day to give us a little bit of feedback. We'll mention that again in a moment. And so for those of you who don't know our team, Dr. John Higginbottom, this is really his brainchild, this platform. So we're very appreciative to him. And his vision was really to provide evidence-based and evidence-informed practices, and to get us really as a people delivering services, receiving services, loved ones, having a conversation about best practices and how to advance this work in whatever way we can within healthcare systems. So today I'm speaking, that's Regina, and we have a great team behind us and with us, and that from Jenn Cusick, who's in the room as well. So she's going to be on the hot seat today, asking lots of the good questions. And Manny Ebot is in the background too, just along with Jordan with our technology. So just so you know who you're working with today, that's our little motley team. And as mentioned, our initial funding came from the Ministry of Health. We are very grateful at this time to Douglas College, who've just provided some extra funding to help us just continue this work, at least until the fiscal year. So big shout out to Douglas College for their help and their financial support. Also big thanks to so many of our presenters. We have at least 56 free webinars of high quality, we believe, on our website. So much gratitude to our webinar instructors, because honestly, they do this for love and kindness. And so there's not a lot of financial remuneration, but we really appreciate their time and their energies and their efforts to, again, help us advance good mental health care in our systems. That's a little slide, just a little bit more specifically about our role. But before we proceed today, as Douglas College staff, we wish to acknowledge the Coquitlam and the Kikwa First Nations, as well as all Coast Salish peoples on whose traditional and unceded territory we live, learn, play, and work. Again, I mentioned the evaluation. Jen will send you the link at the end of the session today. And we just really appreciate hearing from you. I know of late, people have not been sending too many pieces of feedback to us, but if you please do send us feedback, we read it, and that's what makes us a better system. So we really appreciate that feedback to us. Should you be interested in doing a webinar for us, we'd love to hear from you as well. And just feel free to email myself or Jen or Manny, and we'd be happy to chat with you. So we come to today's presentation. So we have two wonderful people in the room who've just honestly shared a lot of their time and passion with us over this last year. So we're very grateful to their support and their time. So first of all, we have Anthony Neptune, who has worked in the mental health field since 1987 on both hospital and community settings. I must say I met Anthony a few years ago, we will say, in that community setting in mental health in Vancouver. That was when we both looked a little different. But anyways, he is a manager within the mental health and substance use program at Fraser Health, and Anthony is currently the manager lead for redesign of community mental health services across all sites. So it's so great to have his experience with us today as we think about systems and systems change. In addition, he has responsibility for service to families, as well as overseeing the contracts of a number of services delivered by nonprofit area agencies. So please be sure to check out Anthony's past PSR Advanced Practice webinar from last February, and he really afforded us a great session and information on leadership. So please do check that out. And again, we have a familiar and wonderful face with us as well, Angela Louie, who has worked in the mental health field for over 25 years in acute care, day program, community mental health settings. So really a broad scope of experience as well. She's currently the coordinator of rehabilitation and recovery in Fraser Health, mental health and substance use. And over this last 10 years, she has championed the recovery clinical system within Fraser Health. She's participated in delivering education sessions on living at risk clinical practice guidelines, which align with the recovery approach. So not two easy things to come together. So congratulations on that work. Angela is an accredited speaker and was the silver medalist in 2005 World Championships on Public Speaking. So I think I certainly learn a lot when I see Angela presenting. And I have to give Angela a shout out as a fellow occupational therapist, and I really appreciate that lens that you bring personally as well, Angela, to the work of rehabilitation and recovery. So again, check out please Angela's past psychosocial rehabilitation and advanced practice webinar, Considering Recovery and Living at Risk in Residential Facility Programs. I apologize. So I think that's really groundbreaking work, and thank you again for sharing that information with us. So, of course, we have dear Jenn Cusick, who many of you are familiar with as well and probably have communicated with. Jenn has been an advanced level RAP facilitator since 2007. I've had the great privilege of taking some training with Jenn. Many of you on the line likely have as well. So you know that she brings a wealth of experience and joy to her work that I think we all benefit from. She first brought RAP to Fraser Health Authority in 2002. That's a jolly long time ago, and has supported the growth of RAP in Western Canada. 2015, she left her peer support coordinator role and bravely created her own business called Luminate Wellness to share what she has learned about wellness and recovery within an even broader community. Jenn also provides contract work for both PSR Advanced Practice here and also PSR Canada. So we're very grateful to her coordination, technology skills, and also just really her expertise around health and wellness. So with that, I pass you over to our speaking team today. And thank you very much to all.
Hello. So we're going to approach this a little differently than we might normally on a webinar. We're thinking we're going to have kind of more of a dialogue. And feel free, if you have any questions or comments or thoughts, to type it into the chat, and Regina will speak it out, and we can answer as we go. We'll also leave some time at the end to answer some questions. So the goal of today is we're going to talk a lot about RAP and about how RAP started, but I believe it has application when you start any new program, because there's risk, there's challenge, there's struggle, and I think we can share with you a little bit of how the process was for us in bringing RAP here, and hopefully you can find something out of that story that will support you in starting some kind of new initiative, whatever you're doing, wherever you want to implement that. So yeah, so that's our goal for today, and it's going to be fairly relaxed, and we're going to be open to answering different questions if you have some. So first of all, before we dig in, we want to talk a little bit about the core competencies of practice. And Regina, I don't know if you feel comfortable, I have them right here, if you feel comfortable just adding a little bit to it. So the first one that we're going to kind of be addressing is domain C, and that one is psychosocial rehabilitation, supporting practices, and recovery-oriented services. So that, if you can all look at that right now if you want to go to the PSR Canada website. So it's PSR RPS, which is the French, Canada.com. And on the very first page, you can click a link and it'll bring you to a document that is the core competencies of practice. And I'd encourage you to save that, because there's some really great information about applying this these type of principles to whatever work you do. And what we're doing today, we're talking more so in the domain of C, which is the recovery-oriented practices, but we're also going to talk about how leadership plays into implementing these practices. So domain E is facilitating change and providing leadership. I don't know if you have anything else you want to add, Regina.
So I'm sure that you probably pulled up the website at this point, but I think two things to really pull out. I guess C1 really speaks to PSR practitioners being familiar with and aware of, I guess, the diagnostic criteria and the illness, and then not only that, but just really being aware of how those things can really impact somebody's daily life and their function. So just having both the knowledge of the illness piece and having the knowledge of how that can impact people. And of course, I think C2 really speaks to helping individuals articulate, become aware in a way of how those illnesses really impact themselves. So as a practitioner, really important to, I think, learn from others in terms of they impacted the illness, and then really helping individuals, walking alongside people to support their awareness and development of really the daily impact and the kind of supports people need, and helping people being able to ask for those supports. And I guess on the E section is really thinking about how our systems support those kinds of opportunities for people to learn to grow. And you'll remember as well, the Mental Health Commission guidelines published 2015 speaks as well to that transformation of services to become more recovery oriented. So just trying to align the competencies and the work of the Commission, and then highlighting, I guess, just the work that Fraser Health is doing around implementing some of those things.
Excellent, thank you. Before we really dig in, I thought it would be cool to find out where some of you are from. So if you want to, in the chat, just say where you're from, what maybe what role you have, and it would just be great to kind of hear that from you. So feel free to type in. And also one little technical piece, when you're chatting, can you click the chat button, not the Q&A button, because the Q&A button will not be monitored, because I don't know if you can see that, Regina, and I can't reach it from here. So only use the chat button, don't use the Q&A button. Thank you. So where are people from? We've got North Bay, Ontario. Oh, wow, it's going fast. So we got lots of people. People from Kelowna, Central Ontario, Williams Lake, Vancouver, Nova Scotia, Sydney, Nova Scotia. My mom was from there. Hamilton, Ontario, Regina. Oh, wow. Oh, Selkirk, Jen and Pam. Calgary, Victoria, lots of great places. Yeah, that's pretty cool. Yeah, good. So thank you everyone for joining us. So before we dig in, we thought we'd give you a little bit of a landscape of where things are at right now as far as RAP and within Fraser Health. And then we're not going to take too long on this, but just to give you context of where we are now versus where we came from, I think is helpful. And then we'll dig into kind of how we got to this place. So first, Anthony and Angela, do you want to talk a little bit about what RAP looks like now in Fraser Health today?
So we haven't rehearsed this, so these answers will just come as they come to us. Where we're at right now, it's a very interesting place, and right now we have Fraser Health staff. We have staff that are working for non-governmental organizations. We have individuals with lived experience that are specifically employed by their organizations to deliver RAP. And so what we've done is we've really tried to create a network where the goal that I have had is that by 2020, I wanted any individual that was living in the Fraser Health region, living with a mental health challenge or a substance use challenge that wanted to do a RAP to have the opportunity to complete a RAP. That was and the reason that...
Before you continue, how many people is that?
Oh,
because that's good context.
Yeah, so we, at our community mental health teams, we probably are serving in excess of, I want to say about 15,000 people, I believe. I could be wrong on some of those numbers. And the reason that I was never under the illusion that every single person would want to do RAP every single year. But the concern that we had was that we were at a place where we were doing, I think, about 100 RAP classes. 100 people were able to access RAP. 100 people, 120 people a year were able to access RAP a few years ago. And we said that this was such a great program that we needed to shift from that place of just offering it to a relatively few individuals to really making it available as universally as possible. So that was the impetus behind it. And so the place we're at now is that we've got a lot of I call them collaborators, folks that really believe in this vision that we all collectively share. And so we have RAPs happening at our mental health centers. We have RAPs happening in our clubhouse programs. We have modified RAPs happening in other settings where people are using portions of it in inpatient settings because that's appropriate. It may not be the entire thing, but working with folks there. We have folks that are working with adolescents in different settings, days treatment settings that are offering RAPs. So what we really wanted to do was create an environment where individuals were exposed to the opportunity much more. And the other piece of what we've been doing in terms of RAP is that a bit by accident, we've got our staff taking RAP classes. Angela has done an amazing job leading this to get us to a place where if you are a staff member at within the mental health and substance use program, or you're working for one of our affiliated community partners and you want to do your own RAP for your own well-being, we are offering free RAP classes for staff. And so we're in this place where we're trying to create an environment where we're saying this is a little bit different way of practicing. Because those of you that are familiar with RAP will understand that it's a very different model from how we traditionally deliver mental health services. And so the concept of creating space for everybody to be able to benefit from this. I remember when I did my RAP a few years ago, and Angela had said to me, you can't have this idea around everybody getting access to RAP and you not go and do your own RAP. And so, but the eye-opening piece for me, and I think this is instructive, is that RAP, and when you make a decision to work a certain way or make a decision to make services available a certain way, and you're truly open to, let's see where that goes, it takes you into unexpected places. So we didn't start off and say, oh, we're going to do this by 2020 and this is the roadmap. We said, we're going to do this by 2020. We're going to figure out how to get there. And we needed folks to come along and say, well, have you thought of this? Have you thought of that? Have you tried it in this circumstance? Have you done this? Have you done that? And so that's what's really helped us in this process. We're not there yet, honestly, but I think we have definitely laid the foundation. And I have to really credit my colleague, Angela. If any one person really did the heavy lifting in terms of this, it was Angela, because I might be the person that talks about where we need to go and try to help pull together some resources, but she was the person that made it happen. So.
Oh, can't see my face because this is in the way. Sorry.
Just tip it down a little bit. Or even just tip the. I was thinking it's the.
Oh, is it the mic that's in the way?
Oh, okay. Sorry about that.
Okay.
I'm okay with it being in front of me. Did you want to add anything, Angela?
Well, I think even, I can't remember how many years ago it was now, but I know a number of us came together in a focus group even to decide whether it was RAP that we were wanting to deliver, because, there were a lot of structures that we needed to make sure we followed. If we had RAP, there were certain trainings that needed to be followed, refreshers, certain type of material. So we were deciding whether to follow RAP or to develop something that was entirely Fraser Health homegrown. And the focus group that we had actually pretty unanimously decided that it should be RAP because of how it was developed in the first place. It was a, grassroots kind of program developed by peers. So, once we were locked into kind of choosing RAP, and even though we only were developing, we were able to deliver, I think, 12 workshops a year, 100 people went through. Still, it was at least consistent in our region. So it was 3 years ago or something like that, 4 years ago, when Anthony decided, we need to do something to increase our capacity. So that's when we went down the road of thinking, how can we increase our capacity with no extra money for people? So
no one's ever heard us anybody in government say, hey, do
No
this with
money.
no money.
So we looked to our staff group that we already had. So that's when that whole idea started taking hold. You know, could we actually involve our staff group? Could we involve our workforce? So that was a whole adventure in itself.
Mm-hmm.
Yeah.
Mm-hmm.
And I think that part of that, and I give credit to a colleague, the director that I still report to today, Denise Hood, who we were having a conversation, and I said, wouldn't it be great if 20% of folks could get able to do a rap? And she said, why would you have a limit around how many people? And I said, you're right. We shouldn't limit this. We really need to make it available to folks. But this was, and I can't understate this piece, this idea that you're going to have staff deliver rap. When we had a model that it was solely driven by peers. Mm-hmm. And I think that caused a lot of dissonance with a lot of us, because it was, okay, so if staff are going to do this, what does that mean? Are you actually going to be true to the ideals of this? Does that mean that if I'm a person with lived experience and I'm employed to deliver rap, that I'm no longer going to have an opportunity to do that job? And that's going to be taken away from me. How will we? So those are all. That was a major. That was a major place for us. But the credit to folks that believe in this is that I think it was a leap of faith. I think it was a leap of faith amongst folks with lived experience. I think it was a leap of faith amongst our colleagues that said, yes, I will take this on and I will do this. And I think it was a bit of a leap of faith of our system, because it caused us to have to change some of how we would normally practice and what we would normally expect staff to do. And for those of you that are familiar with government systems, we often have rules and regulations and processes and things that are in place for very good reasons, but those are all things that you have to address when you say, okay, we're going to do this, and we have to figure out how we're going to get there. And so that's the place we've come to it, that we're doing this, and it seems it's not really questioned, but a few years ago, those were a lot of questions.
It was, and I think it's something that probably people on the chat might be asking questions about. No, not yet.
Well, no, not yet, but we did have a question of outcomes in terms of that were tracked in terms of, which I think is really cool, any reduction in sick leave. So I guess that
for
question
staff
was really,
has it been tracked yet?
No.
I
haven't tracked it.
No, we haven't tracked it, but it's an interesting one. It's interesting around the motivation around these things. And so, to be honest, my motivation around staff doing their own raps had nothing to do with their well-being. I'll be honest about that. I was so focused on how are we going to get raps available to the individuals that we serve, and that we're going to be true to the fidelity of rap. And so the commitment that I made to everybody was, if we're going to go down this path, we're going to be true to that. And part of being true to that was you had to do your own rap, you had to live with your own rap before you could train to be a facilitator. And that was very important, we knew, because it was a different way of, it was not expert knowledge. It was personal knowledge around how I've used this in my life, and this is how I can help you in terms of how you may learn to use this in your own life. And so that was a very big part of it. So my motivation was very much, we need staff to deliver this, staff need to do their raps. And I remember the first staff member that cornered me in the hallway after doing her rap, and I hadn't done mine yet. And she said, do you know how powerful this is? And I said, well, yeah, I believe, all of that, the normal stuff that folks like me say when you're trying to promote something. And she said, no, you need to understand how powerful this is in my own life. And the little light bulb clicked. And I thought, Angela was probably already there, but she's worked with me for years, so she knew I probably had to get there a little bit on my own. But, and we started talking about, is there a way that we could expand this? Is there a way that more folks that aren't going to be, and it really challenges you. And so the piece around, does it help with sick time? probably if I took the normal bureaucratic hat, I would be, okay, we're going to offer this. Let's see what the benefit is for us as an organization and blah, 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 and track sick time or something else like that. We actually went from a different place. Somebody said, I think this would just really benefit staff and we should make it available to them. And so we didn't think about tracking. It's probably a good idea if we want to expand that and have more of it, but that was really the place. We came from this place where I still remember the staff member, and I still remember the conversation in the hallway with her, and she first name is Jennifer. I'll never forget this. She said, "This is really powerful," and so that's kind of where we how we got that to that place.
Cool.
So
thank you.
Can I add a little bit too?
Yeah.
So I mean, we've learned a lot of lessons on the way, and I think one of the first lessons that we learned is as we were offering it to, and I think some managers were really on board. They wanted to jump into this. One of the lessons we learned is that we say it's voluntary, but we really need to mean that it's voluntary. People can't feel as though they're pressured or coerced or something like that to take RAP or to become a facilitator, because that shows up in what happens. They're not there necessarily for themselves. They're not there invested in their own personal well-being. They're there because they feel as though they're being told to be there. So that we've learned from that, and just how we approach and present it to people, that it is definitely of your own volition. And we gained a couple of benefits. I know that Anthony has kind of had the idea that we want to deliver more RAPs to our clients, but the couple of side benefits really is that staff have an avenue for their own personal well-being. So it's like an employee wellness option. And I know a number of staff have said to me, this is the first time I have actually, been offered something from Fraser Health to do with me. And that's been really, moving for some people. And the other thing that I think has been a side benefit is the shift in the dynamics between staff and the people they serve. So, kind of a traditional dynamic is I'm the expert and you're my client. And so I know better about what you need. And when people do a RAP, it shifts that dynamic a little bit. So I think staff and clients are both kind of on the same page when it comes to looking at wellness. I have challenges and I've had to deal with them in, my own ways. You have challenges and you're dealing with them in your own way. So we're on the same page going along this journey. So I think it's really leveled the playing field in terms of the, us and them kind of barrier, expert and client.
Awesome.
Well, and one thing to add to that is the amount of advocacy, or whatever word you want to use, that we've heard from staff that have said, I really want a person with lived experience to co-facilitate with me, which was another really interesting development as we've gone on this journey. We're not always able to do that, but I know that that's been a strong motivator for staff that don't have lived mental health or substance use experience, saying, yes, I'm using this in my own life, but yes, I also want, I'd really like to co-facilitate. And that's been a fascinating
and I want to interrupt you for a second there, because I've facilitated a lot of trainings. And a lot of the trainings I've facilitated are clinicians, some clinicians and peers, some almost more clinicians and some more peers. But what I have noticed is, I would say 80%, 90% of clinicians have some kind of lived experience, whether it's a personal lived experience. It may not be a diagnosis, but it could be, dealing with postpartum depression or family mental health issues. So, and I think that is the beauty of this, is that like within the training itself, people are sharing that openly within their teams. And one time we did it, And it was actually Fraser Health clinicians. And they said, one guy said at the end, he's like, wouldn't this be amazing if we did this in all our meetings all the time? Because it just created this dynamic that was different. It just shifted everything. So I think sometimes when we're in a clinical role, we can distance ourselves from whatever kind of lived experience we have. But the beauty of RAP is that it kind of puts it all in the forefront, and it like gets rid of any stigma if there is stigma within it. So anyway, I just wanted that.
Well, and I guess that's part of to me, that's part of this wonderful dynamic, is that the idea, we often talk about, do we create space for things to come into that space? And so some of what we need to do, in my opinion, is that being open to the way things may unfold that may be a bit unpredictable. We may not quite know where it's going to go, but the space is created, and the space that's created allows for you to have some of those real moments for folks. And so that's part of the journey for this, for me, that I think is important, is that when we allow for that space to happen, and we allow for those, and it includes some difficult conversations. I remember some very difficult conversations with colleagues that were peers that were delivering this service, and they had some really good questions, and so that, by having the space for that to happen, I remember some of the first meetings when Angela brought folks together, and there were 30, 40 people around a table that were all qualified as RAP facilitators, and they were having these conversations, and they were all working for different organizations and different structures, and everyone is united around this idea of, we're going to make this happen, and we're going to walk through these challenging pieces around, how do we do this, how do we do that, and all of that. It's very, I still remember that first meeting. It was very powerful, at least from my perspective. So
thank you. So one thing I wanted to touch on a little bit is not just within Fraser Health, but the scope of RAP within Western Canada. So just to give you some ideas, VCH is using RAP. Also, there's an organization in Victoria, VCSS Victoria branch is using it. Island Health started to, but then they pulled back, and now I don't know where they're at with that. As well, within Fraser is definitely the biggest. And then in Alberta, we have Alberta Health Services, and they're offering RAP within their services in Edmonton. And Michelle is on the call here, I think, in the chat, and she has a role similar to Anthony's in Edmonton, so she can type things into the chat if things come up that you want to share, Michelle. That would be great. And we just recently this summer did a training in Manitoba with different agencies represented there. So it's very, very early stages for Manitoba, but it's very cool. And also, Regina, I don't know if you wanted to, are you coming here to ask?
You know what, I'm coming to ask a question, because it seems when I ask it from over there, they sound as wonky. But one person was really curious about the need for certification and recertification. Is it necessary for high fidelity?
Yes.
And they just asked that in the context of, a remote setting where travel is expensive and hard to manage.
Yes. Before I answer that, that's a big question. And Regina actually is recently got RAP happening here at Douglas. So we're going to be doing 5 RAPs for the students within Douglas College. So that's pretty cool, hey?
That is excellent.
Yeah, so that'll start next month. And we're going to try online, we're going to try in person, we're going to do different ways so students can access it. And for those of you who don't know RAP, I'm going to give you like an elevator speech on what RAP is, just to give you some context and why it is the powerful program that it is. RAP stands for Wellness Recovery Action Plan, and it was created by a woman named Mary Ellen Copeland. She herself was struggling with mental health issues, and this was back in the 80s, and she wanted to figure out how to help herself. So she asked, it was kind of before the recovery movement that we know now, and she asked her doctor what she could do to make herself well. And the doctor said, well, I can prescribe you this, or give you this therapy. And she's like, no, I want something else. So she worked with a vocational counselor and decided to survey people across the nation, the US, and find out what they did to take care of themselves. And this was like years ago, before we had internet, before we had Survey Monkey. So it was like actual pieces of paper that she mailed in the mail, and she ended up getting 125 back. And there were pages added, and people wrote on the back and added extra pages. So it was she got a lot of information, and she was unwell at the time. So she would stick it in a Rubbermaid container and shove it under her desk. And then when she had a moment, she'd open it and look at it. And what she found, it was kind of like a rudimentary research project in a way. What she found was there were themes that people had noticed, themes that they used within their life to stay well. And those themes are what we now call the key concepts of recovery. And that's hope, having that drive to that spark that gets you out of bed in the morning, taking personal responsibility. All of us know that if we're not in the driver's seat of our own life, we're not going anywhere. We're just going to sit, right? So it's about that. And it's also about education and being a lifelong learner, learning about myself, learning about the world, and taking that kind of education approach. And then self-advocacy is a big one, learning how to figure out what I need and figure out how to get what I need and how to go about it in a way that's helpful. And then support, because we're all wired for support. We need community, we need belonging, and that's a big piece of it. So she started doing workshops on just that, and people came from all over and loved it. But some of them found that it was a little bit too abstract. So that first group that she taught this to thought, well, let's add a little more context to it. And they created RAP, what we know is RAP. So wellness tools are things I can use to stay well. And then there's 6 parts of RAP. The first part is daily maintenance. So that's looking at things I need to do every day to stay well. Well, what I'm like when I'm well too. And then the second part is triggers. And we are actually looking at they're changing the languaging around triggers and calling it stressors now. So what are the things outside of myself that are causing me to, go off? And then the second piece of that is an action plan. So when I'm feeling triggered or stressed, what can I do to support myself in it? And again, the key concepts weave into everything we do. So the important piece of triggers is there can be, when we don't fully take personal responsibility for our triggers, we can start placing blame. So the beauty about RAP is that we look at triggers, but we also go, even though these things happen to me outside of me that I didn't choose, I'm the only one that can change it. So what can I do in the situation I'm in right now to support myself? And it's about taking responsibility for that right now. And then early warning signs is like looking at what are the internal things that are causing me to go off balance. This one I really believe teaches us a lot about self-awareness, like paying attention to what's happening in my body. What am I feeling? Is my heart racing? Am I thinking negative thoughts? Am I feeling my tension in my muscles? All that kind of stuff, creating awareness around that. And then what am I going to do when I notice it as an action plan? And then the fourth part is when things are breaking down. So if I may be doing everything right, but I still find myself that I'm not in a crisis, but I'm on the verge of a crisis. So what does that look like? And the action plan for that needs to be very it can't be really broad. It needs to be like, what are the 3 things that I do when I'm in this situation? Because I can't handle a lot of choice, when things are breaking down. So what are the most powerful things I can do to support myself when I'm in that situation? And then the 5th piece is creating a crisis plan. And this, what I've noticed in my work is the power of writing this can actually support someone to not have a crisis, because in a way it's like, or when they do have a crisis, it's like you're creating your crisis plan so that you can stay in control when life feels like it's out of control. So if I go into a crisis with that in place, I can get back on my feet so much faster than if I go in and I'm just swimming around in this mess, right? And that's so, so powerful. And we can often in a RAP group, we say, like, define what a crisis is for you. It doesn't necessarily mean that you're going to end up in the psych unit. Like, I actually used the crisis plan for when I had my second baby. I created a birth plan using the same formula, and there was mental health aspects for me too. And it really, like, I wish I could tell you the whole story, but it was like, it changed the whole outcome of my birth. So you can use it for different things if you're having surgery or all sorts of stuff like that. And then part 6 is post-crisis. So what can I do after a crisis to get back on my feet quicker? So yeah, so that's wrap in a, like, really
Wrap and a wrap.
Wrap in a wrap, a quick wrap. The fidelity piece is RAP has something that we call the values and ethics, and everything we do comes out of these values and ethics. And I could post maybe Maddie, if you're there, you could go to the Copeland Center website and just Google values and ethics, and I think the document will come up and you can share that in case anyone wants to see that. And I think the thing that makes RAP so much more powerful than other programs is the fact that it is grounded in those values and ethics, and fidelity is really, really important. So we train facilitators that this is like sacrosanct. This is sacred. And things like this is, everything's voluntary. We believe each person's an expert on themselves. We approach everything with unconditional high regard, everyone in the group. And one of the values is we stand shoulder to shoulder. So even if we're not someone with a diagnosis, when we're facilitating, if we're an occupational therapist or if we're a nurse, we take our hat off at the door and we facilitate as equals. That I'm not an expert to tell you what to do. I'm here to support you on your journey of self-discovery. And we're going to create an environment where you can believe in your own inner expert. And it's amazing how people have really respected that, who have other roles. And it does get complicated. And I've had lots of people email me and say, what do I do in this situation? Because it's my client and it's not. And I'll tell you that those, and I think the point of everything we're saying here today is there is discomfort and there is wrestling and there is dialogue and there is a lot of difficult conversations, but they can be worked through. And I think it's beautiful that they're asked, that these questions are asked, because it means that it's working, right? And another thing about the fidelity, that you have to be trained and refreshed every 2 years. And that is pretty much non-negotiable because of the fact that it is so grounded in the values and ethics. It is so different than other trainings, and it is so easy to kind of go off base and have values drift. So a big piece is to have that getting back together and getting back on track as far as the values are. Online, the Copeland Center offers online refreshers, not facilitator trainings. The facilitator trainings have to be done in person. But the Copeland Center does offer refreshers online, so that's an option.
Okay.
Yeah, that's
something new.
Yeah,
that I didn't know.
For you, it wouldn't really be worthwhile because it's like $700.
Oh,
it's like if you're a remote person out in Timbuktu, then it would be worthwhile, but for you, it's not really worthwhile.
Yeah, just to speak about the model here is that we've I think 3 advanced level facilitators,
yes,
if I remember correctly, and this has been tied to we're funding those positions through 2 community agency partners. I think that the piece around drift is actually a really significant thing. Mm-hmm. The experience that I've had and has been in services, oftentimes there's a model that's developed. So I want to talk about something that's completely not related
not on our list.
not related to RAP at all. And I'll give an example in Fraser Health of something that had happened a number of years ago. many of you that are part of this chat are familiar with the individual placement and support model, the IPS model. And evidence-based model, it's a very strong model. We know that it works. We know that all of these things. And that model came to Fraser Health a number of years ago, and probably 20 years ago, plus I don't know exactly when, I wasn't here. But that model talked about a specific fidelity and how to do the practice. And so it was brought to Fraser Health, but there was no commitment that we're going to stick to the model. And so what happened was, over time, and this is a true story, we had in one community, the vocational counselor was doing more work like if she was a recreation therapist, and was doing excellent work. I'm not criticizing the work that the individual was doing, but it wasn't IPS. And in another community, the person said, well, I think people need, they're not quite ready, and we need to make them go through some hoops. And then that wasn't working. Anyway, long story short, we had this mismatch of vocational services across the health authority that didn't look anything like IPS, except for one of our community agency partners that said, we are sticking to the model, and we will do it even if the health authority doesn't mandate us. And they were having some great results. So when we started to look at employment, I said, is there a way in which we can have greater consistency around this? Because I felt that it was important that we address this issue of supporting individuals to get jobs. Because I don't believe that having a mental illness, living with a mental illness, means that you should live in poverty. That is just something I do not agree with. And so we looked at the different models and we said, actually, there's this great model. It's evidence-based. It's been available to us, but we haven't been doing it. And so what it required us to do was bring everybody together and say, and it was a difficult call, we are going to follow the fidelity for this model. It means that if you are a vocational counselor, that you're either directly employed in our organization or you're in one of the services that we contract with, you will follow this model or you will do something else, and somebody will come along and do it for you. And some people left. Some people said, this is not really what I want to do. And we said, okay, well, thank you for making that decision. And the result that we have now is that at every one but two of our mental health centers now, there is IPS vocational counselors, and they are getting people jobs, and they routinely review the fidelity, and they sweat it as a group in terms of how well they're meeting the fidelity, and we struggle sometimes in some of the places, and as an entire group, and they represent 3 separate distinct organizations, Fraser Health and 2 contracted agency partners, and that group works really hard to stick to this, and we see the results. And the culture has changed in the organization. We went from a place where people would say routinely, that person isn't well enough to consider getting a job. That staff are saying, I'd like you to work with this person. I'd like you to work with that person. Managers are saying, how come I don't have this resource available on my team, etc. And so that's the commitment to fidelity. I think that when we have things that work, that we know that have been researched, that are effective, oftentimes the challenge isn't that people don't care, but there are other pressures out there that pull us away. This other task needs to happen. This other responsibility needs to happen. And so if we can make a commitment that we're going to follow the fidelity, it gives us an anchor point. It gives us a place that we can then come back to and say to folks, there's a reason why we're asking you to work in this way. There's a reason why we want you to practice in this way. And we're going to support you in your practice. It caused us to do some things that we weren't doing in terms of supporting people in their practice to be able to do this work. So it's not as simple as saying, oh, you're going to follow fidelity and then you're going to put all the responsibilities on the staff and then you leave them and they're at their own wits' end. It's that you make a commitment as an organization that if you're going to do this, you're going to make some hard choices. You're going to prioritize something over something else, and you're going to have that guide some of your decision-making process so that you can come back to it and say, there's a reason why we've made this decision. There's a reason why the job descriptions all look the same. There's a reason why there's this particular structure in terms of who you report to and who provides your practice support. All of these things are connected to this idea that there's a model, it works, there's evidence behind this model, and we have made the decision to follow it. So those are, and I don't want to minimize that that's not an easy process. I think that can be a really difficult road, but having that as one example of a way in which you anchor it is the way in which I think can give you some strength, in a field where we're facing lots of challenges and there's lots of demands and lots of expectations. And so this isn't necessarily always the easy choice. This is sometimes the more difficult choice to make.
Yeah, thank you. And another piece about fidelity is when you, I'll answer that at the end, another piece about fidelity is if you look at RAP now, RAP is across the world. So you can take a RAP class, a RAP workshop anywhere in the US. You can go to Hong Kong and take it. You can take it in Ireland. You can take it in, Australia, New Zealand. It's all over the place. Even Guam, does RAP. So what is so powerful is that you could take a RAP in Guam and you can take a RAP in Chilliwack and you're going to get the same quality service, right? So I think fidelity is so important, especially because all of us as creative individuals want to change things and we think we know better, right? And we want to add things and shift things, which as a whole, RAP looks at, adjusting and changing as a whole. But if it's not going to change for one community, it's going to change for the whole system. And I think the Copeland Center has actually done an amazing job with keeping the fidelity. And I think it's very important to respect that because it is there for a reason. And it's evidence-based for a reason because we do follow fidelity. And I think it's important. Anyway, so I want to give we're on question 1 now. Just a brief overview of the early days, because I think it's kind of fun to hear that, where you've heard where things are now, but to hear where it came from can sometimes be inspiring because everything starts very tiny and small, and that was the case for us. So actually I worked not directly for Fraser Health. I worked for a nonprofit and we were contracted through Fraser Health. And back in those days, our budget was okay. It wasn't fabulous. It wasn't huge or anything, but we still had some freedom within our budget to be able to do some new things. I had a manager at the time, Peter, he was actually on the board of PSR Canada. Peter Andres, do you remember him? Yeah. Well, of course, you know.
Peter and I sat on the board together.
You were on PSR Canada?
Way back in, yes. Well, PSR BC. When he was on board there, yes, so that's that history.
Yeah, so Peter was on the board of PSR Canada. So he used to always go to the conferences. So there used to be a yearly conference. He went to this one conference in Ontario. So PSR Canada actually is related to RAP. It's pretty powerful in a way when you dissect it all the way back. So he went to this conference and there was an organization from Phoenix, Arizona called Meta Services who did a presentation on peer services. Peter was there and he's like, this is so good. And so one thing that I loved about Peter and his leadership style, he was very he was a linear type of thinker. He was good with money. He was, that type of person, but also wildly innovative. So balancing that kind of intense, his wife was a accountant and he liked things in a row, but he also was willing to take risks. So he came back and he's like, Jen, this organization was so good. I want you to go visit them. Yeah. So he paid us, me and 2 people from my team, to go to Phoenix, Arizona and visit this organization called Meta Services. This was back in, I can't even remember. It's all sort of hazy to me now. It was like 2001, 2002, somewhere in there. RAP only started in 1997, so it was very new. The Copeland Center didn't actually exist. So this organization called Meta Services they were looking after RAP. So we looked at all their different programs. They had peer support training. They had kind of a CREST type service. psychiatric services. They had work programs. It was like amazing. We were just blown away. And I remember we also sat in on a wrap. And on the very last day, I was like feeling like, whoa, you know, what do we do? We're so far behind. And I said to a group of people, I'm like, what if we could do one thing? What's the one thing we do? And they said rap, hands down rap. So we're like, okay, let's go back and do rap. And I'm certainly not advocating this because now we know the right way to do it. But I didn't know the right way to do it back then. And also the process was new. The Copeland Center didn't fully exist. So they didn't have a lot of it was not evidence-based at that time. And I think it's important to talk about that because sometimes we only want to invest in evidence-based programs. But this wasn't old enough to be evidence-based at that point. But there was something magical that you could tell that was different about this program. So Peter, we got back and Peter's like, sure, do it. So, but I didn't even know there were trainings. So we bought the books and we started doing that. And it was rocky, very, very rocky. But then I did go to a conference put on by RAP in Massachusetts. So Peter also supported us to go to that. And we met the executive director. So it was when the Copeland Center was announced, the executive director was announced. I met him and he was like, oh, like, because he wanted us to do it the right way. So he came alongside us and he agreed to do a conference for us, remember? One thing I should mention is also our budget was, Anthony wasn't in his role now, so he didn't oversee our budget. It was someone else. And this person had almost nothing to do with us. So, and I don't know if I've ever told you this actually. So we took our peer support budget and we're like, what's a good number for RAP? And we just pulled a chunk of the budget into RAP and just created our own RAP budget. And because it's so brilliant that we did this actually, because we did this, we had a pretty rich budget. So we were able to do 15 RAPs a year. And we were able to get a lot of experience and our facilitators really knew what they were doing. It was, if we had have started slower than that, we may not even be where we are now because of that. So anyways, we did a conference and Anthony was part of the planning. It was a 2-day conference back in 2005, right?
Remember that I had just joined Fraser Health at the end of 2004. So the timing is really good. And one just comment about that too, though, is that I think some of that groundwork had been laid because folks had been talking about the recovery movement and where we needed to go. And your organization was seen as one of the organizations that had credibility around that conversation. So I think that, you know, you need the stars to align clearly, but I also think you need to have an environment that's open to it. And I think you were in an environment that was open.
Yeah, I really was. And I'm so grateful. I think back to it now and it's like, I think just everything was in place, including your role, including the organization I worked for, even to PSR Canada, you know, that it all aligned, that it worked out like it did. That's not to say it was smooth sailing, right? So we did the conference. We got, how many people came out? Like 200?
Yeah, it was a lot.
Day?
There was a lot. And, you know, this thing around fidelity, I remember about this, because at the time, people wanted to go off and just run their own RAPs, and some people started doing that as a result. And so I still remember those hard conversations around, you've got folks just going off and doing this, and they haven't got any training, and what that's going to be.
And we did, thankfully, because the Copeland Center executive director was involved then, he kind of held our hand, and he got us all trained, and we started doing it right. And I'm still connected with them because of that. So it's been pretty awesome. And I know Fraser Health actually is still connected with the Copeland Center quite clearly. So it took a number of years, because how many years? That's 16 years ago? No?
Yeah.
16 years. So it took a long time, and it took, I remember the early days, we'd get a lot of pushback, like RAP, like, what is this? Who is this? who are you to be doing this? You know, because it wasn't clinician run at all at the beginning. There was a lot of pushback, but then we had so many people come through that had, you know, life-shifting experiences. So then slowly we had wait lists, and then we had more people, and then we did the conference, and then trainings, and then more communities started offering it, to the point slowly over 16 years to where we are now.
Yeah.
So.
It took some really, and I think there were a bunch of steps without going through time, without going through all of them. I think that one of the things that I would say was consistent throughout this time was that there were folks that were in places of leadership, whether they were your organization or my organization, that trusted. And we said, trust us, this is the right way to go. We need some help here, some one-time dollars, whatever it was. And that helped to build. And every time you do that, you put another building block in. You help to strengthen your foundation. And so as you grow that, it doesn't all, and it can be organic. I still think to this day that the delivery of services, there is a place for the organic growth of things. We do less of that today than we did in the past, but I still believe that there is an environment that if you can trust sometimes and say, like you said at the time, that there wasn't evidence-based. But I will say that we had a good understanding of what was working and what was not working. And there had been a lot of work that had been happening around that you could look at something and say, how does this align with what we know works, or does it not align? How does this walk beside somebody versus telling them what to do, our old ways of being? And so I still think that even if you have something that may not be evidence-based, I would say it's definitely informed by evidence before you have been able to fully demonstrate it. And individuals with sound critical thinking skills can look at something and say, and folks, more importantly, that are experiencing it can say to you, this is working for me. And that's, and sometimes that's the most powerful thing is to experience somebody that says to you, this is making a difference in my life. I would like other people to have the same experience. And what a powerful, that testimonial, I think, can really help us propel us forward.
Awesome, thank you. There was a question about, is there facilitator training in Canada? So since all of this, I have actually left my role, and I have my own role that I support agencies across Canada to develop RAP. That's one of the things I do. So if that is something that you wanted to do, you're welcome to email me and I can talk with you about how to go about doing that. We're also talking a little bit about, you know, what if we do like a RAP conference here? So that's something that's in the back of my mind, which I don't know if I should say aloud, but I did already. So here we go.
I'm used to this.
You can help me do it.
You know, those ideas, right?
I was crazy idea. Anyway, okay, so my next question is kind of ties into what you were just saying, is the whole idea of innovation, and how innovation and doing something new always 100% always involves risk. And especially when something isn't evidence-based and something has to be done and repeated to become evidence-based. So how do we know well, you already kind of answered this, but how do we know what to pick and what not to pick? And then within that, how do we sit with that discomfort? So I just read this book this week called, it's a neuroscience book called Deviate, and it's the art of thinking differently. So it's about perception and it's about creativity and all this stuff. And basically he was saying all creativity involves uncertainty, and uncertainty is scary. So how do you walk into that uncertainty? If you want to be an organization that's innovative, that's creative, that's interesting, that provides new ways of challenging the status quo, it means stepping into that risk and uncertainty, which feels so scary. It feels scary because I don't know if any of you out there paint or write or do anything like that. I'm in the midst right now. I've been writing a peer support curriculum for a long time. It's been 5 years in the making, and I'm at the end. But I am starting a new module right now, and we have all these ideas happening. Like, how do you get it into one document? How do you like organize all your thoughts? And I know when I'm in that process, I feel so overwhelmed. So and it feels like, how is anything good going to come out of this? Because it feels so messy. So I actually spent hours and I wrote sticky notes, and I have about 50 sticky notes right now on my wall. And it feels so messy. And I think when we're in an organization and we're starting something new, that uncertainty and that messiness is going to show up, right? It's going to be there, and it's going to be uncomfortable. And it's sometimes a lot easier to not do it, because then you don't have to deal with those difficult feelings. So as leaders, my question for you is, how do you create an environment where people feel safe, where within budget constraints, within resource constraints, how do you create a space where people can feel like they have room to innovate and to be creative and to be take risks? That's the question for you. Whether it's rap, like we did it with rap, we did, and we just talked about how that was.
Mm-hmm.
But what about the future? What about what's happening now? Like, how do you, as a leader, do that?
Well, maybe Angela,
Is that a big question?
Give a sense of her experience with that. I have some ideas for that.
Well, I think a lot of ideas actually come from the people who are working in the field. The clinicians, or support staff, or whoever's working in the field, often will hear about or have gone to conference and learn about something that they think is innovative, or they've been in a committee and there's a discussion about something that they think, oh, this needs to be pursued. And if you have good leadership, then those ideas can be talked about. And there might be some good ideas that the leadership takes up and runs with and says, pursue it. Let's see what can happen. So I think that's happened with us with a number of innovations. You've talked about IPS, but one that's happened in the last couple of years is something called sensory interventions. That was an idea that came out of one of my colleagues being in a committee and seeing, hey, this is something that we should be doing, and why aren't we pursuing it? And Anthony, I think, nurtured that idea. So now it is something that is a regional initiative across all of our mental health programs. So, that was an innovative idea. It was evidence-based, but it was still not something that was being practiced at all in Fraser Health.
I think, and to add to what Angela has said, sometimes I remember something that I learned in university when I was doing my undergraduate degree. This was a long time ago now, but it's always stuck with me. I was taking a course around change within governmental systems. And the professor talks about how there are times that there are great ideas, but the bureaucracy doesn't support it. And one innovation that you have to do is you hold on to that great idea and you look for your opportunity. And so what that means is, so yes, you create an environment where you hear and you learn and people can bring things forward, which I think is very important. But there are times when you have to be incredibly strategic and you have to time it. And so the experience that I had is Angela had come to me with a great idea. It's a strong model that we're using right now. And it is a model that, interestingly enough, just to put it into perspective, we have a recovery-based model that we're utilizing across our tertiary system, our community mental health system, our housing program. And when Angela brought the idea forward, I remember us meeting with the director that I reported to, and Angela had a student there, and we were crammed into a tiny office, and we were selling him on the idea. So that was the sell, that was the pitch, and he got very excited about the idea. And he said something really interesting. He said, let's try to move it into this setting. And we all went, yeah, but they're the least receptive to this. But over in this corner, there's a manager that's really keen to do this. Why don't we do it there? And so what it took was that the idea was solid, there was interest in it, and then there was opportunity. And I think this piece around opportunity is you cannot understate that. And so there are times where you'll have an idea and it will sit in the back for a few years. And there are times that it'll just happen because there's an opening. Mm-hmm. And that willingness to step into that and say, I have this, I'm looking for an opportunity, and if the opportunity doesn't present, and then there's all of the work that's involved, and the work is just the work, but the being strategic at times is, I think, something that's really critical for us, is that it's right that there are some things, because we've done a number of things, and I'm really proud of the organization, but there are some things that I've wanted to do that we still haven't done. Oh, okay. So as an example, I have for 10 years more than 10 years, had an idea around how we can have more peers working in our emergency departments. There are some amazing models out there where this has happened. We haven't done that yet. Right. I'm not letting go of that. And whenever there is a chance for me to try to influence someone, I have brought that up for years. Now, at some point it'll happen. I'm one of those people that believes that. And someone will say, wow, look how they did it. And I'll be sitting there going, yeah, I've been at this for years thinking about this. Whereas there are some things where the ground is very fertile and you're able to step into it. And so I say that because I think sometimes when we present about these things, it makes it seem like it's easy, that it's effortless, that it wasn't difficult, that we didn't have setbacks, that we didn't face challenges where people literally closed the door in our face or didn't respond to our email or didn't agree to take that meeting. And so there's a certain amount of resilience that's needed for you when you're doing that. And there's also a piece that I think if you're in a leadership role and you're working with your colleagues on something and say they're subordinate colleagues to you, it can be very debilitating for staff to sometimes think, things aren't going anywhere, nothing's happening. And so part of it is to create as much space for open dialogue as possible, because the folks that have worked closely with me over the years, sometimes they've brought an idea to me and I've said, there's just no way we're going to get this to fly right now. It's a good idea, but I don't think the timing is right. Other times I've said, yeah, I think this is a great idea, I'm going to take it forward. And sometimes I've come back and I've had to be really honest and say, okay, I can't tell you exactly why, but we're just not able to do this now. But trust me, I think something may happen down the road. Or other times I've said, okay, we got this pushback and that pushback, we've got to go back to the drawing board. And so it's that there's no linear process to this. There is no formula that says, I do believe there are some principles that we've talked about here today. And I do feel that piece around the willingness of an organization to be open to these things is part of the exercise. And so if you're in an organization that hasn't got that level of openness, then maybe the effort that you need to do is not about the program, but how can you support the creation of that environment? What can you do to create the opening for that possibility? When we think about change management and different things, we often know that it's not about one single strategy. It's often about the fact that it might be exposing people to things. I'll give you a really quick example. We, in my career, and it happened just this week, and we were at a planning day, talking to people, and we heard from a family member that had a fairly negative experience in our system, and we had purposely had this family member at the session to share with folks that are in leadership roles around this very negative situation. And what it did is it hit me. I remember saying to my colleagues, it was like a punch in the gut because this happened just last year. And I thought, how is it that with everything we've done, that this is still happening? So the point of it is this: that story needs to be told. That we need to have an environment that person can be heard, because I think that leads to change. And oftentimes what happens is, in my experience, the most powerful thing that can catalyst for change can be hearing from the persons that we serve or that we should be serving, and their positive experiences and their negative experiences. And having an environment that's open to that opens up the possibilities for other things. Because if you are hearing from folks that say to you, what you're doing right now is not working, it may create the space as an organization for you to say, we need to look at opportunities to do things differently. And then when somebody comes in and says, we've heard from people that what we're doing isn't working, and here is an potential answer to that. So the focus being, have you created the space for that voice to be heard? And I have no idea the outcome of what's going to happen from that family member sharing their story, but I guarantee you it's going to have an impact in terms of how we deliver services and what we do going forward. And that's the point. And somebody like Angela or someone else will come forward with an idea and we'll go, I remember that story from that family member, and I think that this idea that Angela has brought forward might address that. And all of a sudden, you're ready. Whereas maybe in a vacuum, I might have said, yeah, it's a good idea, but I don't know why we need to do it. So that's, so to me, that environment, and when we talk about environment, that's aligned with recovery and how we work together. And
so I want to ask you something about what you just said. So Fraser Health is like really lucky, and I don't work for Fraser Health anymore. So, and I see it from an outside perspective, but really lucky to have someone like you who is in a position where you're a leader, but you also have people above you. So you have an opportunity to create that environment. I know within my work with other agencies that some agencies don't have someone who's a champion like you to kind of create that opening space that you're talking about. So I guess a little bit of, if we could draw from your wisdom, how did you come about being able to see that, see the importance, and what did you have to, I know this is kind of like a big question, but what do you have to do personally? Because we all have our biases, right? So we all have our biases. We all have the way that we think things should be. And in order to be a good leader, we have to learn how to put that aside and be able to see things differently. So how have you as a leader done that to be able to create these open spaces?
I made a lot of mistakes.
And Angela too.
Yeah, I honestly made a lot of mistakes. I say it's an easy question for me because I did things in the past that were not helpful to the individuals that we served. And they were kind and brave enough to tell me that that's what I was doing, that it wasn't helping, and I was contributing to their discomfort. And I can remember all of those conversations. I remember the things that I screwed up on. And what struck me around it was that oftentimes I thought I was doing the right thing. And so for me, that's been a driver for me. And so what had happened was I started to think that there was a lot of things that I just didn't know, and I don't know what I don't know. And so how can I be open to learning that? How can I put myself in a place? And so I've used structure. I believe firmly in the International Association for Public Participation Guidelines for engagement of stakeholders. It is a driver behind how we have worked, and health authorities across the province now are using that with the work around patient engagement. I discovered that many, many years ago and said, here is a structure and a framework for helping me to understand how to work with stakeholders. And those sort of principal things and learning from people and hearing from them has shaped me. And then when you are shaped in a certain way, I feel for myself what's happened is that it has it's created an expectation in myself that part of my role is, I have a bit of a mouth and I speak up, and but I also believe that if you're a person that's going to come forward and say, I don't think this is working right, you have a responsibility to come with solutions. Mm-hmm. And coming with solutions isn't about you figuring it out yourself. It's around how can you learn from people. And so to me, I'll admit it's a little bit of a philosophy. It's a way of living. It's a way of being, and that's how it's worked for me. I've recognized that not everybody's going to have the same style and approach. Angela and I have incredibly different styles, and I would say that she has been equally, if not more, effective in bringing about change in our organization. So at least for me, that's how I've come to this.
Mm-hmm. Do you have anything to add?
Well, I do feel, like you say, incredibly lucky. I do feel incredibly lucky that I've been a part of this particular team that I'm a part of, because the stars do need to align, and you do need to have leaders. Like, I've been working with Anthony for a decade or so, that we can work together towards a common goal. And that isn't always the case, when you're on a team. Mm-hmm. So I think that, yes, it has been an incredibly fortunate time that we can move ideas forward. Mm-hmm. So, yeah. So let's hope it can continue.
Well, and the one thing I would add to this, though, is that let's say you're working for a small agency and there isn't a lot of opportunity there. Mm-hmm. I guarantee you that there's somebody else in your community that might be willing to take this up. Mm-hmm. Sometimes the way in which we look at things is that, and I'm guilty of this too, is that sometimes I think, there's only this one route, or these two routes for me. And maybe what I need to do is, there's two things. Sometimes you have to say, okay, if I feel so passionate about this and I can't do this here, then maybe I need to be somewhere else. But I think that's pretty drastic. So maybe the idea is not around, okay, my organization may not be willing to take this on, but do I know someone else that might be able to take up this cause, that they may be in the right environment for the stars to align, where there's an opportunity. And so I've always believed that we all have some ability to impact change. Some of us have greater access. Some of us are in places where we can make more things happen. I recognize that. We have differences in power and hierarchy and all of those things. But oftentimes it might be that there's someone else somewhere along the line that is doing something, and maybe you don't actually get to be the person directly involved, if you're helping to bring the idea to them, or bringing the opportunity, or even bringing two people together or a group of people together, or whatever it is, to be the catalyst. And so that's the piece for me where I think that because it can be discouraging. Mm-hmm. It can be discouraging that we've done things with staff where we've said they've been excited and they said, I've learned so much, but if I go back to my organization, I'm never going to be able to implement this. Mm-hmm. So how do you then keep that flame alive? Mm-hmm. And so are there other ways in which you can do that? Are there other strategies and approaches? Mm-hmm. And sometimes you do things that are really a little off the wall. I mean, part of what we've done in some cases is that we've gone directly to the individuals we've served and said, well, we can't do this, but you guys can take this on. You guys can promote this. You can speak to this. And so maybe our work is with individuals. I still remember when Regina and I worked together in Vancouver many years ago. We had a situation where we were trying to, we weren't working directly together, but we were in similar work. And I remember working with a number of clients where we knew that when we were exposing them to real choice and freedom, that was not the rest of their lives, that they would go back to places that were very restrictive. And someone said, is that a good idea that we should be exposing clients to choice and making decisions for themselves and that? And we said, of course it is, even if it's only for 2 hours a day. Mm-hmm. And so what does that lead to for that person? I don't know where that goes with that person, but it's about, creating a little bit of that space. So I couldn't change the facility that the individuals were living at. I couldn't change those dynamics. I had no ability to do that, but I had an ability to expose the individuals that I was supporting with a different way of being.
Mm-hmm.
And so to me, that's no different than my ability to sit down with an executive director or a vice president and say, I'd really like for us to do this, and here's our model, and which, broader scope. I see it as no different than when I was working with that individual, and I still remember those individuals, allowing them to have a real choice.
Mm-hmm.
And that took work.
Mm-hmm.
I spent 3 months working with someone to get them to choose what sort of artwork they would do, or if they would play a game, or if they would go for a walk. Because when they started working with us, they thought they had to do what we told them. And it took 3 months to this point.
Yeah.
And I remember the day I still remember this. This is more than 25 years ago. I remember the day that individual started volunteering at the place that we had exposed them to, and was going there independently and getting the keys and unlocking and setting up and doing all these things from a place where he was just about tell me what to do. So that's right. And so we all have an ability to influence. And what doors open because all of a sudden now that person that maybe some individuals saw as not capable is very capable. And so to me, it's like these principles around recovery and our belief around our absolute, everybody on this call, on this chat, our absolute belief in individuals. We absolutely believe in individuals. And so that's sort of that inner thing that we can do, I think. And so anyway, those are my passions. That's how I would suggest for those that are isolated and may not have the same sort of advantages or opportunities that some of us have.
Thank you. I'm going to make one plug and then we'll go to questions. But like you were talking about, a community of practice is so important to have that place where you can gather and have a community of practice. So one thing I have another little contract with PSR Canada, and we are developing right now an online community of practice for people across Canada. You have to be a member of PSR Canada and then you'll have access. So it'll be an opportunity, a space where you can go in and talk about this kind of stuff in an online type of setting. Because sometimes, especially like when I was in Manitoba, I was moved by how small towns were and how remote they are. And having that connection is so important when you live in one of those types of spaces. So that is coming. It'll be coming down the pike in within a month or so, but it's for members. So if you want to be a part of it, you need to be a member. So let's just take a few questions before we end. I mean, we're supposed to end at 12, but I mean, if we're okay to stay, we can stay a few more minutes. And then if you have to leave, you can leave. Is it okay if we go a little bit longer? Yeah. And then if you need to go, you can go. And if you want to stay, you can stay. And we'll just answer a couple questions. Did anything come in, Regina, that?
I think we've answered most of the questions that came in. I think you've actually taken care of all of the outstanding things. But maybe we can begin just a discussion. And I just want to say I was really inspired. I think that you helped us bring us back to that emotional sense and the values and commitment to why we do this work, about working with individuals to help them identify what's important and necessary for them. And that those kinds of conversations can indeed impact larger systems change. I had a conversation just last week with Dr. Terry Krupa that maybe most of you know. She was just speaking to about how we've developed a lot of service systems, put a lot of money into vocational services, which of course we know are tremendously important, necessary for people. You spoke about poverty and the need to give people the opportunity to participate. But also in my conversation with Dr. Krupa, we also spoke about these other services that we need to develop for other areas, because maybe not everybody is interested in the employment section. And I just thought they were very wise words. And I really like how we're having systems talk today about how we implement change and how we value emerging ideas and practices, and how it takes a long time for those ideas to become what we now call evidence-based practices. but just the value of listening to the people that we're serving, the value of putting ourselves out there, taking the risks. And I love the idea as well about passing on ideas to others, such that if our organization is not the right service to meet specific needs, that there are others. So I hope you can hear part of that on the mic, but just checking in here. This person had a few questions about documentation, presentations, and outcome measures. Any information about that? So
For RAP?
I think so, yes, for RAP.
So with RAP, we it's voluntary and we never take notes. So one of the pieces of RAP is that we want to respect people's confidentiality. So that has been an issue, I know, within Fraser Health, because everything has to be tracked. So the things that we can track with RAP is attendance. We can track, you know, an application form, a certificate, those types of things, but we don't ever track how people are doing within the RAP group or anything they've shared because of, you know, the values and ethics and the confidentiality piece. So I don't know if you want to say something. Were you going to?
Well, I was just going to jump in as well to say that this project that we've mentioned already at Douglas College, we are making it a bit of a research project. So we're asking people a little bit about their experience of participating in RAP, and we want to do that because this is one of the early times that we're trying to bring this model to a college or university. So we acknowledge that McGill is doing a little bit of this work, but we would have really liked to be able to put this work in the literature if at all possible. And so absolutely respectful about what people say. And of course, not everybody will give us permission to be part of the research study. So very respectful about that. But just some pre and post questionnaires so we can help learn a little bit and about people's health and wellness.
I should clarify what I said, because we do always within a RAP group recommend doing a pre and post and an evaluation. So that is a piece of it, and people usually do it anonymously. What I'm talking about charting, we don't do charting, we don't do progress notes. So we don't do, you know, week one, oh, so-and-so talked about this, so-and-so talked about that. We don't do any of that because that's not a piece of the values and ethics of RAP, and that's a piece of holding the fidelity.
So maybe I can speak to, so what we do in Fraser Health, we do a pre and post, just how people see themselves, what they know about RAP, and, you know, their awareness of some of the information. And we, you know, we have an electronic client chart called Paris. And so what we instructed our clinicians to do, so when our clinicians are the facilitator, and there might be, you know, several of the people who are clients of the mental health center, then what they're required to do is to open a Paris group, a RAP group, and they do need to take attendance on those people. So there's some context, you know, session 1 was about, you know, the wellness toolbox. Session 2 was about this. So there's nothing charted about what was actually said, but it's more about the attendance and, you know, what the information that was delivered.
And this gets tricky. I remember the conversation around someone coming to a RAP group and they were intoxicated, and what has to happen, and should the case manager be informed, and all of these things. And so, you know, one of the things, it goes back to this fidelity. We said we're going to follow the fidelity, and so it challenges us. And so part of the piece was, is there a different way to have a conversation with that individual that they may want to include the people that are supporting them in what's going on?
And just another piece about, you know, we do have some meetings quarterly to support our RAP facilitators. So we do come together in smaller groups and larger groups to share some of these dilemmas. And what do we do? How do we handle them as facilitators? So that's a way for people to kind of, you know, become more comfortable dealing with these situations, especially if they are used to having a different hat on.
Yeah.
And I think over the years, you know, there are still situations that come up, but it's our clinicians that have more challenging, more discomfort around having two hats. And I think over time, that has been eased, like just with experience and dealing with some of these situations, they feel a little bit more at ease with these dilemmas.
Mm-hmm.
So, yeah.
So I know we're running out of time. Hopefully that answered the question around making the case for supervisors refunding. So I guess we're offering that taking attendance is good. Also, please let us know that there's a fair bit of literature out there as well that you could use maybe to shape your manager's thinking in that direction. That might be helpful. So let us know if you have any trouble finding it. Let us know. We can help you. And then there's a final question of does the college guidelines and how you communicate important information from a professional's perspective. So I guess that question straddles both the health sector and the college sector. And I'm sure Angela and Anthony have ways that they wish to respond to this question. I guess for us at this point, we have set up this project such that all of our students will come through the counselors. And from my perspective, it just allowed that extra little bit of cushion and support for people so that we were accepting that support a little bit through the counseling department so that when people are coming in, we will be able to say, well, please follow up with the counselor. So it's about keeping confidentiality, but it's also just providing a basket of services for people as well. So I'm not sure if Angela and Anthony want to respond to that too.
So, I mean, in terms of like extra support outside of the RAP group, is that what you're talking
Well,
about?
I think the question really stemmed from this idea, maybe from, or at least I thought it was, from if somebody turned up at a group intoxicated, or maybe there's a pressing issue that you're worried about within 4 people. And, how do you manage that within a clinical or,
That's a big question to answer. And
Sorry, go ahead, Angela.
Well, we start with this premise, and that is with a support document. So in a RAP workshop, we come in with the idea that people are becoming aware of themselves, they're developing, or they already have strategies to manage their own wellness. And some of those strategies may not seem like they're good strategies to us. Some of them may seem a little bit unusual, but they are their strategies. So it's that individual's strategies for their own wellness. So it's not for us as a facilitator to judge that strategy. And what we've been encouraged by our advanced facilitators is if there is something that's affecting the group, then maybe we can discuss it as a group. If something is happening, what do we need to do maybe to look after ourselves, like the support document says, what do I need to do to support myself today? So that's kind of the starting point. And then hopefully, things can develop in a productive way.
If I could just say something quick. What Angela touched on is we used to, within RAP, have like group rules or group guidelines. And that used to be what we did. What we found, and I've been thinking a lot on this over the years, but I've been thinking about it recently too, is what has happened. We stopped doing that because rules can be arbitrary. Rules are sometimes for the sake of the comfort of the facilitator, that we can go, oh, we said no cross-talking, or we said confidentiality. But what really matters is creating an environment where people feel safe and people feel like they want to be, that they're respected and they want to respect others. So that is the most important piece. And having rules does not matter. If you create that space, then I have noticed since we've shifted, I've had way less interpersonal issues in groups since we got rid of the rules and started talking about a support document. So what a support document is we say at the very beginning, because we talk about personal responsibility and self-advocacy, we say, what will I do? And I talk about myself, and if you guys were in the group, you talk about yourselves. What do we do to support ourselves through this group, to feel safe in the group? And that has shifted everything. So if I'm feeling triggered, if Anthony is doing something, maybe he's like tapping like this, right? And it's annoying. I can say, well, we need to have a rule that we don't tap in this group. Well, instead of doing that, then I go, that tapping is annoying me, and I'm going to take personal responsibility. So I'm going to move over there because being beside Anthony is too much for me. Sorry.
You said that many times over the years, so that's okay. I'm used to it.
But you get what I mean.
No,
So
absolutely.
it's like instead of me blaming you, it's like I get to take responsibility and move somewhere else, and that creates a different shift in the environment.
It does. Well, and part of this for me is that
We could talk for
we
10
could go on
hours.
for a lot of times, but I guess really quickly for me, part of this is that I think some of the ways we've traditionally responded to things have been about risk, and it's been about our discomfort and thinking that we're going to get into trouble by somebody or some risk. I also believe that some of what, and you know, one of the powerful things about when we started talking about RAP, people said, well, how is their case manager going to find out what happened if you're not going to document on it? And the answer was brilliant. The RAP facilitator said to me, every time we have this, we talk to people about who's part of your support group, who's part of your support network. Is your case manager part of your support network? And I think it says something if the person says, no, the person isn't, and I don't want them to know anything. That says more about that person that's supposed to be supporting the individual than the individual that is seeking support. So our systems have to be about when what we're doing isn't working for the person is not at fault. That's a powerful way for us to. So, so I could go on and on about this, but I think that a large number. I don't have a specific number, but I'm told by RAP facilitators that most people that are being served by some professional desperately want that person to know what their RAP plan is. There are very few people, thankfully, and I think that this is backed up. We've recently done a survey of folks. We've had more than 900 respondents coming to mental health centers, and one of the highest scoring areas was the relationship between the individual receiving service and the clinician that they were working with. Our staff do a very good job of developing relationships, positive relationships with people. When you have a positive relationship with someone, they want to share their RAP plan, not because they have to share their RAP plan, because you are there as part of their support network. And I think that that's the way in which we have learned so much in the last few years around, harm reduction, the opioid crisis, all of these things. And people that receive services successfully are saying it's about relationship. It's about how that I feel supported by the individual, the professional, the doctor, the psychiatrist, doesn't matter who it is, that's working with me, as well as my family and natural supports. That's how we have to orient our services. And so it's not about, and that meets our college guidelines, that allows us to be in a place where we're serving the individual. They're volunteering the information, and we're without us having to be rule-based.
Yes.
And so that's my little plug for that, is to really be thinking about those relationships and not saying, does the individual has to fit in our box, because of all of the various college, nursing and social work and different groups, there's a uniformity there about developing the relationship with the client, that therapeutic relationship, however you define that. And that isn't from a rule-based place. It's from a place of how can you serve someone where you haven't been able to do that work and develop that relationship. So I would encourage people, as I worry sometimes we default to, we can't possibly do this because of that. Check with your colleges. Check what I've said. Don't just take what I've said at face value, but my experience in those conversations is that's where they say that's what we need to be doing in our work, and that's how we not get around in terms of a workaround, but that's how we address these risks and those things.
Yeah, thank you. And I realize we're way over. So thank you, everybody, for joining us. And it's been a great conversation. Thank you for coming, Angela and Anthony. It's been really fun. So
thanks for having us.
Yeah, thank you. Bye for now, everybody.
See you next time. One more before Christmas.
Oh, we're having another webinar actually on December 14th, so join us.
See you then.